Welcome to Vision 2020 USA's Spotlight Series. Today's topic, NORC, U.S. Vision and Eye Health Surveillance System. Featuring Dr. David Rein, Senior Fellow and Program Area Director of the Public Health Analytics Program, and John Wittenborn, Senior Data Scientist, both from NORC at the University of Chicago. The Spotlight Series is hosted by Dr. Rajiv Ramchandran of the Flom Eye Institute at the University of Rochester and Dr. Dean Van Asdale of the Ohio State University College of Optometry, leading members of the Vision 2020 USA Executive Committee.
Great. Well, today's spotlight for our Vision 2020 meeting is on the Vision and Eye Health Surveillance System that was is supported by the CDC, and we have Dr. David Rein and Dr. John Wittenborn, who are from the NORC group out of the University of Chicago, who's been helping to run this and develop this platform for vision surveillance in our country. And I'll turn it over to them to introduce a little bit about their background and what they're doing and how this is really advancing our understanding of public health in the United States for vision and eye care.
Thanks, Rajiv. Hey, everyone. Good morning. I think the slides, so for some in the group are very familiar with this. So I know Jeff and Sandy and Dean are very familiar with it, and Dean especially, the slides are going to look familiar. For the others that are here, we really want to, I think the intent of this presentation is to give a background on why CDC decided to create the Vision and Eye Health Surveillance System, some information about how we built the system, and then some highlights about what's in the system and what's coming out. So with that, I think John is going to control the slides. So if he could share screen and get started.
All right.
Okay, so yeah, it's basically an intro to the CDC's Vision and Eye Health Surveillance System, and we're hoping you'll be familiar with the system and curious about using it after this. And I think maybe areas for discussion would be how we can use VES and also improve VES over time to meet vision objectives, vision health objectives. Next slide, please. So it looks like a very simple presentation with only 3 items: the motivation for why we built the system, how we built the system, and the next steps. But I think you'll see there's kind of a lot that goes into each of those. Next slide. We'll start with just the motivation. I always feel like this is nice to start with to ground the conversation. Next slide, please. We introduced this using some slides from CDC's Public Health 101 series, which talks about an introduction to public health surveillance generally. Next slide. And in this course, they define surveillance as the ongoing, so over years, systematic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice. And it should be closely integrated with the timely dissemination of these data to those responsible for prevention and control. I think we often take an old-fashioned view of public health in terms of there being a public health core that's getting the data as soon as it's updated and looking to act on that. I think the reality of public health activities in the 21st century is the group of people who are working on conditions, particularly chronic conditions, are wide and broad and include both public sector employees and people in university, private sector, state and county health departments. And one use for data is to give shared amount of information about what is happening with vision and eye diseases across the country, so people can coalesce around decisions and strategies to help people who are having vision and eye problems. Next slide, please. In terms of a public health approach to really any health problem, surveillance is at the beginning of the cycle. So surveillance is a process of collecting data and information to describe the size of the problem and any elements within that problem that are changing over time, or where there are population level differences, for example, health disparities that need to be addressed. From this initial surveillance information, multiple public health actions can be developed from, but in terms of those subsequent actions, within this public health framework, surveillance is really the basis of that. It's our ability to understand what there is to do and to monitor whether the subsequent steps are affecting change in that. Next slide. I think it's important to talk about some other sort of uses for surveillance data. We often get questions of, you have all these data, what do people do with them? This slide is an adaptation of a WHO framework for the uses of public health surveillance information. And there's several important elements that surveillance data serve. So one, identifying newly emergent health problems. Two, assessing the public health impact of those problems. Three, identifying correlative risk factors for disease acquisition and progression. We're all aware of a good deal of research that's been conducted over the past 2 or 3 years relating vision impairment and blindness to social determinants of health. This is an example of item 3. Allocating resources and research investments. So basically, what are the most important problems that we should be focusing on? 5, evaluating the effectiveness and impact of interventions, policies, and strategies. This is something I feel like we could be where we could get better over time as we understand the programs that are in place to address vision impairment and blindness and have the ability to monitor trends using best data over time. And then 6, supporting research inquiries and scientific hypothesis generation. So we have lots of indicators in VEST that are rarely used until someone is very interested in that specific eye condition or that problem. And when that happens, the VEST data are really the only systematic data sources for the specific eye condition that they're looking for. Next slide, please. Prior to the introduction of VEST, surveillance of vision and eye diseases was fairly limited. There were limited and dispersed data sources, which I'm not going to say there were no analyses of these. There were, and some of them were quite good. However, across studies, different researchers use inconsistent case definitions, so they define the same condition different ways. They use different measurement methods to look at those conditions and different reporting standards, which made different studies difficult to compare, both across conditions, so comparing something like glaucoma to AMD, or within conditions, comparing one study of glaucoma to another study of glaucoma, or comparing studies across time. There were also lack of resources for additional data collection and curation. And then also, I think it's important to keep in mind that vision and eye health are quite complicated. There's other conditions, for example, dementia, where you really are looking at one outcome. There's complexities to that, and there's things to understand about that outcome. But when you're talking about vision and eye health, you really need to track all of the different conditions and disorders that affect the ocular system, which can result in needing to collect a lot of data to truly understand that. Next slide. So as an example of how complicated the state of vision surveillance was prior to VEST, we pose a simple question: how many people have vision problems? And the correct answer is, well, that depends. How are you defining vision problems? What do you mean by vision problems? What type of data are you looking at to evaluate vision problems? When was the estimation completed? When were the data collected? Who's included in the sample? Um, what survey or diagnostic codes or evaluation measures did you use to measure it? And how did you report the data out in your research? Next slide. So given the sort of dispersed level of information about vision and eye health in the early 2010s, I think there was a general consensus that there was a lack of consistent surveillance estimate, which was limiting public health efforts to address areas of need in vision and eye health. There was a strong desire for surveillance, but there were limited resources and federal authority for direct case reporting. And there were two specific calls for CDC to implement a vision and eye health surveillance system that were really essential to moving the process along. The first was a CDC expert panel on surveillance of vision disparities with co-chairs Paul Lee and Sheila West. And I know Sheila or Sandy, you were on that committee. Many other distinguished people in the fields of optometry and ophthalmology were on that committee. Jeff and Prevent Blindness were involved in this effort. And this led to a direct charge from the expert panel to create a surveillance asset to respond to healthy people objectives so that CDC would have the capacity to monitor the impact of their programs to change vision and eye health over time. The second was a 2016 report from the National Academies of Science and Engineering and Medicine, which includes a direct call to develop vision and eye health surveillance that includes end-stage outcomes and also allows for the identification, staging, and monitoring of the conditions that cause it. So if you think about the NASM report, it's not enough to just follow vision impairment and blindness. You really need to also track the conditions that cause it. Next slide. So from all of this consensus, the vision and eye health surveillance system was born through a cooperative agreement with CDC and NORC, first signed in 2015. And the charge, going back to the point about limited resources, was to establish a vision and eye health surveillance system using exclusively existing secondary data sources. So can we use the data that are already collected and available to have better surveillance metrics of vision and eye health surveillance? And this has led to almost 10 years of project work between CDC and NORC and our incredible partners who are listed below. I won't read them all out. But this is really a collaborative effort which would be impossible without the contributions of each of these team members. Next slide. So now I'm going to turn over to John to talk about, so that's kind of what we were doing. Now John is going to talk about how we did it in a super easy set of 4 easy steps. So John, take it away.
All right. That is right. So 4 easy steps to build your own vision and eye health surveillance system. So we'll go through these a little quickly. And so, David really covered the motivation. So this was our approach. So basically we started with identifying the data. Remember, we have to start with existing available data. So we found all the data. Step 2 is creating case definitions and figuring out how we're going to actually measure outcomes. Then we were kind of left with a pile of data. So step 3 was making sense of it. How do we put it all together, especially across multiple data sources? And then step 4 is pretty important, is how do you report this back out to the community? So identifying data and containing information on vision and eye health. So the data, we looked at 4 different sort of flavors of data: examination studies, national surveys, claims and encounter database, and the IRIS registry EHR data EHR registries. So for examination studies, there's sort of two types. We're all familiar with sort of the population-based studies like Beaver Dam, things like that. They provided comprehensive eye exams to generally the typical design is they identify a specific geographic area and try to make a census of basically vision and eye health among residents in that area, report that prevalence. And then examination surveys, which by that we were talking about the National Health and Nutrition Examination Survey, or NHANES. It's a more limited exam, but they do it in a nationally representative sample, which is pretty key. And so the first thing we did as soon as we signed our cooperative agreement was we started doing a systematic review of published studies, and we selected studies for inclusion for meta-analytic estimates. And the strength of these examination studies is they are a comprehensive eye exam, and you can get the diagnosed and undiagnosed total envelope of vision loss or eye disease. But we identified a lot of limitations with these. They're small, non-representative samples generally. There's a lot of variation in case definitions and measurement methods. They don't include every population. They don't include certain age groups. They don't include people in group quarters, nursing homes, some socioeconomic or demographic minorities were not always fully representative. A lot of this data is super old and not being sort of frequently updated. And we put it together and they're all over the map. So we saw very similar data sources, and they get widely disparate estimates. So it's a little difficult to make sense of it. The next flavor of data was the telephone and interview surveys. So we identified 60 national surveys containing vision or eye health related questions and 178 different unique questions among these surveys. So tons of questions. And some surveys ask the same question, but even sometimes there's just minor variations. And then there's differences between the surveys. So some are telephone, some are in person, some are mixed methods. The sample frame is quite different across different surveys, and that can drive differences in outcomes, including response format. Some are household response, so one person in the household is responding for everybody. Some are person level response, people are responding for themselves. So the strength of these are large, nationally representative samples. They have recent ongoing collection. Remember, a key requirement for a surveillance system is it needs to be systematic and ongoing. So that gives us that. It's better geographic coverage. We can get state, county, sometimes maybe zip and tract level data, which is what we're working on now. And some even have people who are really excluded from a lot of the population-based studies, like people in group quarters. That could include, nursing homes, residential care facilities, prisons, college dorms, all kinds of things like that. But these are fundamentally, they're self-reports, and they're not generally validated. And then these also vary widely across surveys. So here's just responses from 4 different surveys, and they're really all over the place. So we did select 4 surveys to include INVEST. The American Community Survey, I'll kind of skip over some of the details, but basically it's got one question. It's by far the biggest survey. It's got the best sampling frame, the best response rate. Behavioral risk factor surveillance system, it's got the same exact question. It's smaller. It doesn't have a great response rate, but an important thing in BRFIS is that it has other health questions, which ACS does not. So things like diabetes is in BRFIS, but not ACS. National Health Interview Survey has, had a set of 20 plus questions focused on healthy people goals, but they're only asked periodically. And the National Survey of Children's Health has 1 question of vision and several on eye care and screening. This has been very important and helpful for kind of seeing what's happening at sort of the youngest ages. Our third flavor of data is billing claims and medical encounter data. So these contain diagnosis codes, procedure codes, drug codes, and they're convenience samples. So these are not representative. The caveat or exception to that would be if you have Medicare fee-for-service plus Medicare Advantage, then you pretty much do have a full census of everyone over age 65 at least. You're not going to get 100% of their care, but you'll represent, 98% of the people. But these are also pretty limited. You're not going to get any undiagnosed conditions or untreated conditions. You don't pick up anything paid by another payer out of pocket, and ultimately you're only looking at customers, members, or beneficiaries of that specific insurer. In VESS, we include Medicare. So we've had traditional Medicare, fee for service for quite a while. We're adding Medicare Advantage this fall. And Medicaid TMSIS, which is basically Medicaid plus the state children's health insurance plan data, or CHIP. And we have some other government data coming online. We have military data coming soon. We're working on trying to get Veterans Administration data, exploring Indian Health Service. And then from the commercial side, we have market scan medical insurance. That's 55 million privately insured individuals. That's pretty out of date, but we've got an update going through the works right at the moment. And we also have some older optometry data from VSP. We're also talking with VSP, hoping to update this, but that's more of an if. So we're hopeful about that. Then our last flavor of data was the electronic health registry. And for this, we rely on the IRIS registry. So this includes like the large majority of US ophthalmology practices. And a strength of the IRIS registry is it'll generally have more detailed diagnosis history than you'll see in the billing claims. So you'll get untreated conditions coded in IRIS that you won't really see in the claims. It's a little easier sometimes to look back at prior diagnoses, but you're still going to miss any undiagnosed conditions. Conditions that are provided not by an IRIS participating ophthalmologist. IRIS registry does have acuity data, which is fantastic, but it's not super great coverage. Some people don't have the acuity data in there, and sometimes it's a little messy. And of course, your sample is really just people who went to a IRIS participating ophthalmologist. So that is a very sort of self-selected sample of people. So it's not representative of the total population. So that's something we have to think about as we interpret the results. And so we had a lot of data. And so okay, what are we going to do? We have to define case definitions to identify vision and eye health measures. So basically, how do we define these outcomes? So we have three broad topics in VESS: visual function, eye health conditions, and eye care services. For visual function, this can include measured visual acuity. We have best corrected presenting and URE, uncorrected refractive error in VESS. There's a lot of self-reported vision problems from different surveys, and then diagnosed visual problems in administrative billing claims and EHR data. For eye health conditions, we defined a two-level hierarchy. So we basically took every possible vision or eye-related ICD-9, ICD-10 code we could find and put them into one big crosswalk. So this took about a year to put this all together. So it's pretty extensive. There's, I think, 7,000 codes. And so every code is linked to something. So there's 17 categories, and within these 17 categories, we have 79 clinical subgroups. So you can drill down at reasonable detail for most conditions. And more recently, we've started adding summary subgroups, which are sort of mutually exclusive subgroups that can help with interpretation. So for example, this could be vision threatening versus non-vision threatening diabetic retinopathy. So basically the advanced versus the early stages. So if you want to do a bar chart, of vision versus non-vision threatening, you can use these. And once we have the crosswalk, we define the algorithms to actually analyze the data, whether it's claims, EHR, survey, or the examination study, and start putting it together. In eye care services, similarly, we have a two-level hierarchy of categories and subgroups. So a category would be things like eye exams or treatment for AMD. And the subgroups would be like an eye exam provided by an ophthalmologist or anti-VEGF injection for AMD. So those would be the subgroups. And again, we had to develop identification stratification algorithms. Basically, what's our analysis approach to identify these in the data? So the case definitions are really designed to try to force consistency and comparability across disparate sources of data. So there's kind of a balance between level of detail and comparability. So that's sort of, we tried to sort of thread the needle there, so we can report the most amount of data while still making it, as comparable as possible, so people can work with multiple data sources. We had to implement data suppression and security standards. And then we had to determine stratification and reporting standards. So which demographic groups, which age groups, which risk factors, what are we going to report? How do people want to actually see the data? All right, now our third simple step is synthesizing prevalence across multiple data sources. So on VESS, you can find 31 different prevalence values for vision problems. So going back to what David posed earlier, the simple question, how many people have vision problems? Well, here's 31 answers to that question. So a couple quotes that kind of maybe relate to this is that we may be drowning in information, but starved for knowledge, or a wealth of information creates a poverty of attention. So like this is sort of the situation we walked into. This is even after we standardized the methodology of analyzing. So these are even closer than they would have been reported before. It's still impossible to interpret this. So can we reduce this information down to basically one number? Can we go from 31 to one estimate? So coming back to the question, well, a lot of the before the answer depended on a lot of factors. Well, now we have a lot of answers to those factors. We have now defined it. We know how to define it. We know how to measure it. We have the case definitions. We have all the data in one place. We have uniform reporting standards. So, that we're well on our way. And we also understand more about the strengths and limitations and relationships between different data sources. So if we look at our examination, our survey, claims, EHR, flavors of data, we understand like where each of these is strong, where each of these is limited, where the biases may exist. So that really helps us sort of understand how these all relate together. And to learn more about that, we did conduct some validation studies with the University of Washington. So we basically put together a sample of ophthalmology and optometry patients, and we kind of walked through our whole sort of process. So from the most, from gold standard eye exams to maybe the most abstract measurement, which might be self-assessment, we got each step of the way. So this is basically for the same people with the same conditions, we replicated each of the 4 flavors of data, and then we can see how they relate to each other. So the indicators would be telephone responses. So we did a telephone survey. We analyzed their billing claims using our algorithms and case definitions, and we analyzed their EHR using our case definitions. And here's an example output. So here's visual acuity. So this is relating the survey self-reports with their actual visual acuity. And this sort of information wasn't sort of easily found before, but there's a lot of attention on should you have a sort of a binary or a scale response question for this. Well, you can see how these perform, relative to their actual visual acuity, which is here on the left axis. So this was pretty important, showing us on a population level, how accurate, reliable are these survey questions? What kind of signal can we get up? But also can understand some of the limitations. So at the person level, you get a lot of sort of nonsensical answers at the person level. So how do you use these in a population level? So now we have all this data. We have a lot more understanding of how they fit together and the strengths and limitations of each. And we can begin to put them together using statistical integration estimation techniques. And we call these the best prevalence estimates. So here's our best prevalence estimates for blindness or visual impairment or blindness. So we went from our 31 answers to our one answer. So this is how many people we think are blind with best corrected visual acuity of 2200 or worse in the United States. So a lot of work to get down to a simple answer. We have these for visual acuity loss and blindness, diabetic retinopathy, age-related macular degeneration, and glaucoma, which is coming out in less than a month. We're excited about that. And then the last step to building VESS was building a reporting framework. The main reporting dissemination strategy is, of course, a website, but also our data portal. So the website, we had initial launch in 2018. And if you go to the website, you can find a lot of documentation. There's documentation pages for every case definition, for every data set. We have a page with all our reports and publications and a lot of information you can be downloaded. There's actually like thousands of pages of documentation if you really wanted to read it all. It's all there for free. And then you can go into the Data Explorer, and that is the primary method where people can interact with the VESS project. You can map, chart, line graph, table. You can do cross tabulations, stratifications, filters, make simple comparisons of all of our indicators, well over 200 indicators available on VESS, on the VESS website. If you need a little bit more than that, you can go to the VESS data portal where you can access the summary data files that we've assembled and can download these. So the thing to remember is these are not, there's no person level data here. We don't have microdata. If you need the microdata, you can go back to the source like we did. This is what we've done is basically we've estimated the prevalence of every possible permutation of all of our demographic and risk factor stratifications. And that could be millions and millions of rows. I think the Medicare file is 60 million records. So there's still a lot of data there, even though it's not person level. And you can, within the data portal, you can view and filter the data. There is a way you can do custom visualizations right there in the data portal, or most people just want to access the data. So you can download it or you can access it through API. All right, well, that is how we built the system and how it exists now. So I'm going to turn it back over to David to talk about next steps.
Great, thanks, John. So no matter how many times we present these data and the system, the first question we always get when we finish the presentation is, okay, what else do you have? What other data are in there? So the VESS is like a dynamic system that's growing, and we're constantly adding additional data sources, additional supporting research studies, and I want to take a chance to tell you what's coming. So the first thing that's coming is more and newer data coming later in 2024. A big improvement to VESS is the inclusion of Medicare Advantage data. I think probably with this audience, everyone is aware of Medicare Advantage and the fact that Medicare Advantage patients are now basically 50% of the whole Medicare population. So the omission of Medicare Advantage data in earlier years was really a major limitation. So in the new update, we'll have Medicare fee-for-service, Medicare Advantage, and Medicare fee-for-service plus Advantage, so you can see the total prevalence across programs. We are also adding, with cooperation from the Department of Defense, military health data system, which will provide the first publicly available estimates of vision and eye health problems, including ocular injuries, among our servicemen and women and their families. So we're very proud to be able to add that. I'm sure many of you are aware of the evaluated measures of presenting vision acuity problems and presenting contrast sensitivity problems that were collected as part of the National Health and Aging Trends Study, or NHATS. These are important because they are the first evaluated population representative evaluated measures of visual function collected since NHANES in 2008, and we'll be putting data from that study for a representative sample for persons ages 65 and older on the website this year. We also have some exciting new data from the American Community Survey giving state-level self-report results for are you blind or do you have serious difficulty seeing even when wearing glasses, broken up by group quarters component. The group quarters overall estimate is fairly easy to access through the ACS and PUMS website. However, these specific breakdowns for estimates for nursing homes, which is of high interest, correctional facilities and homeless shelters are quite difficult to back out of the ACS estimates. So we were able to do a special tabulation in cooperation with the Census Bureau to get these data and put them on the website. And then, our old reliable data that everybody loves, BRFSS, Market Scan, NHIS, Medicare, Medicaid, IRIS, will be updated to the latest available years. Next slide. We also have a new prevalence estimate coming. The glaucoma composite prevalence estimate will be published on October 17th with the national, state, and county level data also posted to the VEST website and the VEST data portal for download and use. We are in the process of updating the visual acuity loss and blindness estimates. And there will be two important differences from the 2017, several important differences from the 2017 estimates. First, it'll be newer, so we'll have an updated estimate. Also, we are building in the ability to stratify prevalence by a diabetes and a poverty SDOH risk characteristic. Potentially, we'll be able to provide smaller geographies than counties, which is very important in places like, for example, LA County, which has 10 million people and is bigger than most states. And more detailed race and ethnicity and age group level results. It's a little complicated, but the results will be superior to the existing ones. We're also in the process of updating AMD and diabetic retinopathy, and the biggest improvement to these estimates compared to earlier ones is we'll be able to break out the prevalence of these conditions by clinical stage, was particularly important for AMD when you think about vision-threatening AMD and the stages of CNV and geographic atrophy. Those estimates were previously unavailable, and we'll be able to provide those. Next slide. We also have a national survey effort, which fielding is complete, weighting is being completed this week, in which we fielded a nationally representative, a survey to a nationally representative sample with 60 questions, which we developed in collaboration with the VEST expert panel, several members who are on this call. The biggest contribution of this is we've never really known what were the problems of people who answer yes to a question like, are you blind or do you have serious difficulty seeing even when wearing glasses? So using the power of the AmeriSpeak, the power and size of the AmeriSpeak sample, we were able to field a sample of almost 1,000 people who self-reported vision problems, and then ask them follow-up questions on the causes, impacts, and outcomes of vision problems and eye diseases. Eventually, we will release the microdata file on the VEST data portal, but we want to do some analysis on it first. Next slide, please. We also have completed research to create zip code tabulation area estimates. So these will provide sub-county estimates of the ACS self-reported blind or difficulty seeing measure. You might ask yourself, well, aren't these available from ACS? And yes, they are, but the issue is there's a ton of noise in those data. So it's difficult to know whether a high prevalence or an extremely low prevalence is the result of true underlying vision problems or a result of sampling noise. So in this project, we applied some methods to assess the reliability of each estimate and then applied some adjustments to stabilize the estimates in order to have what we consider reliable estimates at the ZICTA level. Next slide. Finally, last year we published a pilot study on census tract level assessments of the types of people who have vision impairment and blindness by census tract to create what we call community need profiles. We are in the process of updating these estimates and these methodologies, not just for the pilot area of the city of Richmond, which you can see in this map, but for the entire United States. I won't say we have every census tract in the United States because some were too small to measure, but we have over 3,000 or over 30,000 of the total census tracts that are available in ACS data. Next slide. And in terms of coming events, so things to put on your calendar, 10/17, the prevalence of glaucoma among US adults in 2022 will be published in JAMA Ophthalmology. I'm very excited to have now these summary prevalence estimates for vision impairment and blindness, AMD, diabetic retinopathy, and glaucoma, all completed and on the VEST website. The data will be on the VEST website at the same time as the publication. And then this is my pitch for attendance. We have a session at American Public Health Association on October 29th at 8:30 a.m. The session is called this long name, Using National Survey Data to Improve Public Health Surveillance. It includes presentations about the ZICTA estimates, about the Vision Need Index, about the Vision Survey, and then another presentation from Patrice Hicks about county level determinants of higher and lower self-reported vision impairment and blindness prevalence. And what we're hoping to do with the session is really make the argument that vision and eye health is a public health priority, like at the audience of the American Public Health Association, and use these data to show both the surveillance aspects of the geographic variation of vision impairment and blindness, but also the association of higher and lower levels of vision impairment and blindness with social determinants of health inequities, and other issues of public health importance. So we are going to be pushing this on our LinkedIn and sending notifications out and doing everything we can. Sometimes the APHA Vision Care session, there's just kind of everyone laughs because you end up in a building off-site on the third floor or something like that. But we're really pushing to try to get more attention and bring as many people as we can to the session as possible. So if you are at APHA on that day, or if you were thinking about attending and you don't know if you're going to attend, please attend and please come to our session. And I think the next slide is the thank you slide. So thanks. If you want to get to VEST, there is the website, and you can contact us through the email list, and we're always happy to answer questions about VEST and how you can use the data.
Wonderful. Thank you so much, David and John, for that excellent talk. I just had a quick question on, looking at national sampling of data. The only place that I know that most people get their vision tested on a national level is at the DMV. So I didn't know if that was something that you guys had looked into to seeing if there's any way to tap into that data and see how that interplays with what you guys are doing.
We have not. That's actually an excellent idea. So we will look into that. We have looked at state blindness registries. So we were pretty hopeful that we could collect data from state blindness registries and get those counts into VEST. They were pretty varied and inconsistent. So inconsistently collected with different levels of inclusion by state. Some states didn't have one. So we ended up not including those data, but not thought about reaching out to DMVs. So
I tried to do that in New York State, and they said that my request was too cumbersome. So, but I know that Cynthia Owsley has done this in Alabama and has been successful looking at that and has publications around it. So if you guys have better luck with your clout and your connections, maybe that would be something good, and we could see if that, adds to any more information on what we're doing. So.
Yeah, it sounds fascinating. It also sounds like 50 different DUAs, and which is doable. Like everything is doable, but yeah, that could be a lot of paperwork. But we will look into it and see if there's like a simpler way to do that, or maybe like a coordinating center at the national level that might be able to help us with that. That's a great idea. Love it. Thanks.
Sure.
It is kind of funny. The one self-report question, John showed that list of all the different, the figure of all the different vision questions that are all over the map. Consistently, the lowest reported prevalence of vision impairment and blindness is, does your vision prevent you from driving? So that's not the exact question wording, but nobody wants to say they can't drive anymore because of their vision.
Especially in the United States, and that's a big issue. So
yeah.
So maybe Sandy, you have a question. You're on mute there.
Second. So with the NASEM being released, and one of the recommendations is on surveillance of myopia, are you guys going to look to see how you can address that any better? That to me is just this big unpredictable opportunity to really highlight myopia and of course the complications.
I'm gonna pitch John because we're working on a special project. It's a little top secret, but we can share with this group.
Well, Sandy knows about it. Yeah, we're analyzing trends of degenerative myopia in Medicaid, which is already on VES. But what we're able to do now is we have access that's not on VES to up through 2022. So VES, we stopped. What's on VES? We stopped in 2019 because COVID happened in 2020. Things looked crazy, and then Medicaid got super delayed after that. But we're about to release up through 2022. We can see trends. So that's degenerative myopia. So I think that'll be important. Myopia is a big challenge because there's no good data on it. We can't find good data. And when we start, one of our logos on here was American Optometric Association. We were hoping the AOA more was going to be our source. We are hoping VSP was going to be our source, and neither of them could provide basically prescription data that we would need. So that's a huge challenge. So I know, NHANES is going to come back out this year, next year, and we're gonna have to wait for it. That'll be national level, not geographically varied. So yeah, that's definitely kind of a blind spot we have in our system that we're aware of. It's just a challenge.
It's a little scary because myopia or uncorrected refractive errors are such a big issue on the global level that yet we, as having wonderful data, I mean, I love the data that you guys have put together, but we can't really talk about what true myopia prevalence is, especially in children, which is really where the challenge is. That's where we can make the biggest impact in the long-term complications of myopia. So it's frustrating from being a peds person and a public health person.
Excellent points. Can I add one thing about the new NHANES data that are coming, just in terms of interesting challenges to consider? The measurement technology in NHANES, and also the measurement technology that we're seeing resulting in claims-related records, particularly OCT, has changed dramatically, improved dramatically since the last wave of NHANES data were collected. So I think there's going to be a lot of opportunities for folks with ophthalmology, optometry, eye care knowledge to consider the new NHANES data very strongly and think about what we could say in terms of changes from the older series of NHANES to the newer series of NHANES that are coming out. The data will clearly be better, right? But the limitation would be with newer methods, you see more than what you used to be able to see and detect. And we're seeing this in claims with increases in detection, particularly diabetic macular edema, in claims records. I won't say across the board in every data set, but in many different data sets.
Any other questions here? Well, I have a question on so vision doesn't stand alone. It's a function of a person who has other issues, and there may be other challenges in that person's life that may influence vision. So one, you look at social determinants of health, which is very important. But I'm wondering if there's a way to look at other factors that influence health, such as mental health or behavioral health, and how does that sort of come into play with vision? Is any thoughts of that? And the other aspect of this is like hearing and vision seem to be, two sensory areas, especially in older adults, that seem to coexist and cause various functional issues, including the progression to dementia faster. So didn't know if there are ways and best to kind of look at some of these factors that are not typically visual based, but have influence on vision and eye health.
So I think the best sources in Invest Now would be the American Community Survey cross stratifications by different disability, the different questions in the ACS disability module, which allow you to see the prevalence of vision impairment, for example, the prevalence of self-reported vision impairment and blindness among those with self-reported hearing loss or self-reported cognitive difficulty is the question. There's some issues with that. I do think the new NHANES data, the hearing loss data in NHANES is quite strong. So I don't know their schedule for collection and if it's going to be collected during the same year as the vision measures, but they do collect quite frequently, more frequently than the vision measures. So I think there'll be a lot of opportunities to look at co-occurrence of hearing loss and vision loss, given that the hearing loss measures are also collected in the same years that the vision loss measures are. In terms of mental health and vision, direct measures of mental health, we've never looked at co-occurrence of claims or things like that, but that would be an opportunity. And if that's a priority, the best way to get action on that would be, to state on meetings like this and, kind of keep talking to us so that we can say a lot of people are asking for this, which would, justify devoting resources to looking at, co-occurrence of mental health and vision disorders in sources like Medicare or MarketScan or things like that.
A couple of questions here in the chat. Dr. Quadros always talking about the prevalence of blindness and diabetic retinopathy. Will we ever really know the rates of blindness from diabetic retinopathy, if they've improved over the past 2 decades, looking at VES data?
Yeah, so I don't really know that we know the rates of blindness from diabetic retinopathy. I don't know that the data are that great on cause-specific reasons for blindness and vision impairment. The older studies have a strong art component with the science component. We do have a special study that, so one thing we didn't mention is like there's the VES system, which consists of the website, the data sources, the case definitions. There's also, numerous special studies that we do to try to support the VES system. And we are working on a special study with IRIS to try to understand the cause-specific, the attributable causes of vision impairment and blindness. There's a lot of co-occurrence of eye disorders within people with vision impairment and blindness. So we need to work to clean that up. I don't think we're going to have, I'm not sure we'll ever be able to know over the past 2 decades, but possibly with IRIS, we could figure out a way to track this over time using more recent data and see if rates are improving.
A couple other questions here in the chat. Thoughts on how a service provider, an NGO, or city or county can utilize this data to implement programs in the United States?
That is an excellent question. So, one thing we often get, right, from NGOs, county health departments, localities would be, oh, well, you only have data at the county level, and we really need sub-county data, right? So we will have zip code level or ZICTA level data coming soon, and we will have census tract data coming soon for the self-reported vision measure only. That said, when we did the ZICTA level analysis of vision impairment of the self-reported question, we found that in about 2/3 of the country, the county level data are fine for planning. There's not a ton of within county variations in many of the counties in the US. There are counties, right? LA County, New York County, Fulton County, where I live, where there's substantial variation and we need more targeted information, which we're creating. I think, let's say that you're an NGO working in one of those counties where there's not a ton of variation. I think how you can use the VEST system would be to look at the specific outcomes for your county, compare them to national or state level averages. Maybe not look at all the VEST indicators because there's a lot, but the conditions that are really important to you, like AMD, glaucoma, diabetic retinopathy, cataract, self-reported vision, impairment and blindness. See which ones of those are elevated and then design programs to target that. I also really think that the new vision need index information should be very helpful to local practice, in that the purpose of that is to divide the people who answer yes to the self-reported questions into typologies. So for example, people who live alone, people who are in group quarters, people families with lower income or higher incomes, so that you can understand what types of people in each area of your county, your municipality, what have you, what types of problems they're experiencing, and you could develop a program. For example, our priority is to help people who live alone, who have independent living, who have issues being independent, and we're going to target these census tracts to try to identify those folks and provide services. So yeah, I think there's a lot of ways you can use the data. We are available to provide technical support on that. Sort of a personal passion of mine, like I would love for people to use the data on the local micro area to really try to address vision and eye health problems.
And Sandy talked about the All of Us study. There's some interest in introducing vision testing in that, and there may be. Do you know anything more about that study and the data that may be useful for vision and eye health?
So I know for for a subset, like we have not started like an assessment of the All of Us study to include those data. We should. It probably will be in the next grant period. I know the two big advantages of All of Us are they have EHR records for individual people, and they have the ability for at least a subsample to field questionnaires to people that you identify from the different metrics that are in All of Us. So for example, if we were able to identify a cohort of people in All of Us with diabetic retinopathy from the EHR records, we could use that sample to field a specific diabetic retinopathy survey to ask them about their utilization of care, their healthcare needs. There's just a lot of opportunities to work with All of Us. I have not done it before, so I mean, I know that it's possible, but there's administrative barriers to working with all of these large studies, so we'd have to overcome that. It would be a project to work with All of Us, but I think it's an excellent point, Sandy. And this is exactly why we have these meetings, is to get this type of input. So thank you for the suggestion.
Wonderful. And I don't know, are there slides public available somewhere that you presented today, or can be made available to the group? Is that a possibility? Just asking it out there.
Yeah, we can send them to you if
Sure.
you want to disseminate. Sure.
Perfect, perfect. Happy to do that. And so thank you again, John and David, for this. And I will be at the APHA, and we have actually my colleague is the Vision Chair section head going forward, Karen Allison. So she's a glaucoma specialist. So a lot more discussion there with you all, and hope to have more discussions here at Vision 2020. Next month, we're going to have a session on the 11th of October, it's Friday from 10 to 11, where John Amuro is going to be talking about the CDC Vision Health Initiative, and I'm sure we'll be touching more upon what VEST is doing. But yeah, exciting stuff, and hope to see some great data and use of this data too. I think that may be another talk in the future of how do we utilize this data. Maybe Dean can chip in a little bit too of how he's using it in Ohio in the future. So thanks again for joining, and hope to see you guys again in the October session. Thank you.
Thank you.
Yeah.
Yeah, thanks for having us.
Thanks a lot, guys.
Take
Good
care.
work.